Welcome to the Cutting Edge. We're here to talk to Dr. Pamela Lee, ASCRS 2025, San Diego. Always love being in San Diego, it's so beautiful out here. But today we're going to be talking more about robotics and colorectal surgery. My understanding is you've been using the DV5 platform now, and you were one of the first to adopt it. Can you kind of tell us what's it been like moving up to the next generation, and what are you seeing as the major advantages?
Yeah, so I've been doing DV5 since the end of March last year. So I've done probably around, I don't know the exact number, but anywhere probably from 150 to 200 cases on DV5. It's been a mix really. I do, most of my elective practice is colorectal, but I do cover general surgery call for my hospital. So I do a fair bit of acute care surgery as well. Luckily, I'm in an institution that's very supportive of robotics, so I have 24/7 access, so that's why my case numbers are a bit higher, probably than most people that are pure colorectal, because I do have access to it after hours and on the weekends, for any kind of emergency cases. The real advantages that I've seen in my practice are, number one, the efficiency, not only from the surgeon side because of the heads-up menu, less reliance on the circulating nurse to do adjustments and things like that. Pretty much the only time I rely on the nurse at this point, I say, is when they're pulling out stapler loads, because they open up those one by one. But other than that, I'm pretty much in control of everything. And we've seen about a reduction in about 18 to 25 minutes per colon case that I'm doing right now. And when you break it down in terms of the efficiencies, it's not only just the console time compared to XI, but also the draping and docking and all of that stuff. So the whole team is more efficient in that sense. So it's really opened up a lot of what my COO calls white space in the OR, right? So it's like unused minutes. And we have a very busy, operating room, lots of acute care. We do transplant, trauma, ortho, all of that stuff. And so the more minutes we can open up during the daylight hours to get those emergency cases in is better efficiency for us as an institution. We get more people in. We get people operating earlier. Nobody wants to be doing tough cases at 8, 9 o'clock at night, right? So the more stuff we can push into the regular hours is advantageous for everyone. I've used force feedback, which, I was initially in the beginning, it was, I tell people it was kind of annoying. It felt like an arm collision. And, I've met surgeons who have said, well, I've used it too, I've tried it in the exhibit hall and I don't like it, and it's one of those things where I don't feel like you can really make an accurate judgment as to whether or not you think it's useful until you've committed to actually doing, I would say, 20 cases with it consistently. When we first started using DV5, we did have access to force feedback because we were one of the premier access sites, but then the supply chain issues kind of caught up with it. So I used it for about a month, and then it was kind of gone for about 3-4 months, and so I kind of lost some of my learning curve. And then when I jumped back on, probably in August of last year, I started using it consistently in all of my colon cases. And we've seen about a 30 to actually up to 50% reduction on force on tissue in my cases compared to when I have it off, compared to when I have it on the low to medium setting.
So for people that don't have a DV5, can you kind of explain what you mean by that? Because is it showing up on the screen? Is it something, how do you measure this feedback?
So it's right now, it's something that you can access through the My Intuitive app. So the amazing thing about DV5 too is this whole ecosystem that you have access to even after you're out of the OR, right? So, I've met people that are in teaching hospitals, and the ability to go through with a resident and show them the parts of the case that they did and where they can improve right then within 20 minutes or whatever, an hour, it's uploaded to my phone. You can actually do that. You and I went to residency when that was not available. Can you imagine me?
I don't know if we had iPhones yet when I was at residency.
I know. I had like a cell phone that had you were doing like pager talk on it.
Flip it open.
Yeah, exactly.
Yeah.
So the advancements, right? You get to be ridiculed in the operating room and ridiculed afterwards, as you're going through it. But that ability to teach right in the moment is huge. So right now, in terms of the force feedback, I can go back and I can look and I can see throughout a case how much force I'm putting on the tissue. So it'll measure anywhere from 0 to 6 newtons. And it's almost like a little line graph that you see underneath. And as you go through the case, I can say, well, why was I putting so much force on the tissue in this particular moment? But again, now we're getting into what is the future on DV5. And all of the innovation is coming on DV5 right now. So eventually, in the very near future, it's going to almost have like a speedometer. So that to me is like where you're really going to see more of the real time impacts, right? Because I've said before, you can look at it and it's kind of an exercise right now, a little bit in academics, right? You're looking back and you're kind of going, but there's nothing you can do in the moment, right? But if you are actively using the instrument and you're seeing that you're putting that much work, it's going to make you pull back a little bit more, you know.
And we've all seen it. So when I was still doing training on people that were on XI, whatever, and you get them out there, like just a gallbladder, and you see them grab it, and you're like, whoa, because and this is that whole thing, like I had done enough, and you've done enough without force feedback. That your brain's telling you from the visual, that the cues that you're, this is a lot of torque, a lot of tension, but they couldn't tell, and you were like, why can't you see this? So now, from a training standpoint, I'm sure this is a huge advantage.
Yeah, no, exactly. I mean, when I started on DV5, I think I was at about 1,000 cases, somewhere around there, right? So I was like you, I had visual haptics, right? And I've told people in these courses I have taught, like your brain almost tricks you into feeling like you can feel the resistance, right? Like you can swear there's resistance. You know?
I always tell the story. I was going to interrupt because I tell the story. My partner was training our new partner a few years ago, and she's pulling on something too hard. He's like, stop, but why can't you feel it? And she's like, I can't feel it. Yeah. He's like, yes, you can. And I was like, no, she can't feel it.
She cannot feel it. You think you can feel
exactly.
it. Yeah, no, it's your brain totally tricks you. But the people that are learning on it now with the advantage of force feedback, they're going to get through that learning curve so much quicker, you know what I mean? And so, and a lot of people in the teaching institutions, they are using it on, like, say, the high setting, because it is going to give a lot more resistance to those beginners that are using it.
What do you mean high setting?
So you can basically set the force feedback to off, low, medium, or high. So when it's off, it will still be measuring the force on tissue, but it'll be exactly like you are in a normal robot without haptic feedback. If you have it on the low setting, it will push back on you a little bit, the lowest amount when you're doing something, right? Medium means medium amount of force that it's going to push you back, and high means it's going to be giving you a lot of feedback when you're giving more force. And so you can basically set it and adjust it to how you want. As I said in the beginning, it feels a little bit odd because you almost feel like it's sort of, like an arm collision. The robot will never force you, not allow you to do something, right? But it's how hard do you want to push through that movement in order to get it done.
When I've gotten to play with it, to me it felt like, I always say, the lane assist you see in a car. Like when it first came on, you try to turn the lane, eventually you can push your way into the lane, but the car's going to try to stop you and it's going to try to move you back. The way I felt, that's kind of what it felt like. Would you say it's similar to that feeling, or?
Yeah, so basically what it'll feel like, especially on the high setting, is when you get out to those extremes of the movements where your arms are coming out, you're going to feel a lot more pushback on that. So in the beginning, it's a little bit distracting, right? Because it does feel like an arm collision, But as you get through the learning curve, what my goal was, and I think that I'm there now, and if you look at my data, I'll explain to you in a second about how I think that's translated out, is that now it's not really something I'm conscious about. When I feel that force, I'm just not pushing as much through it. My body is responding, my arms are responding in the sense that I'm not trying to get through that resistance. Does that make sense? And so when you look at the amount of reduction on force on tissue in my first 15 cases, it was around a 29% reduction when you looked at off versus low to medium setting, which is usually where I have it. I don't keep it at high. But when you look at, we just did another refresh of my data, and for the last 120 cases of colons that I've done with it, I'm down about 58% in terms of my force on tissue. And I think, at first when I read that data or saw that data, I was like, that doesn't really make sense. How is it, how does that make sense? But it does, because now I'm not pushing through as much to try and overcome that force, right? My brain is doing exactly what I wanted to do, which is responding to it and not going against it as much.
This episode of The Cutting Edge with special guest Dr. Pamela Lee will return after this.
Welcome back to The Cutting Edge. Now, what about those that say, okay, that's great, you got these numbers, but does it mean anything?
Right. Yeah, so I think that, again, that's a lot of surgeons that I talk to about DV5, they want to know, well, how is it going to revolutionize my practice right now, today?
Yeah.
And there definitely are significant advantages, as we talked about, efficiency and visualization and, the workflow state. I mean, we've measured how many head in, head out, events there are XI compared to DV5, way less, right? I mean, I have to remind myself to pull my head out of the console just to give myself like a break to kind of, you know what I mean, reset. Because sometimes, you know, you need to do that in an operation that's very long. But, you know, the advantages are not necessarily everything that's happening right now, but it's all of these updates that are going to be coming in the near future. You know, ureter identification. You know, this idea, I mean, how many times, you know, I'm an expert colorectal surgeon. I can find the ureter. It's sometimes even hard for me, right? And then when I'm coming across the pedicle, you know, I'm constantly flipping back and forth to make sure I don't have it, right? And then you lose it. How many times do you lose a ureter? You see it so clearly, and then 3 seconds later, you're like, where is this ureter?
Yeah.
I can't find it. You know, high BMI. I had one the other day, BMI 50, it was covered in fat. I found it and then it was gone again. But the ability to give an IV dye, be able to see the ureter without having to get your urology colleagues or get separately credentialed in cystoscopy with injection, which some colorectal surgeons have done to kind of bypass the urology aspect of it, and the time, right? Because it takes, I mean, to put a stent in, I mean, it takes an extra hour of the day, right, to get all the equipment in. And so that ability to be able to just see it, flip it back and forth, not have to reposition and everything like that. I mean, now you're talking about the efficiencies that that are coming in the future. So
absolutely. And then more to the general population, but we know minimally invasive. Obviously, find me the surgeon that doesn't believe minimally invasive is the way to move. But there's still areas around this country where that just doesn't exist. You call them deserts. Is that what you're saying?
Yeah, MIS deserts. Yeah. So I mean, you know, one of the things that I think is incredibly important, and being an acute care surgeon, I think it's, you know, it's near and dear to my heart. You know, it's like one of my drums I like to beat is this idea that, like, wherever, if you ask a layperson on the street, does it matter where you go to the ER, what insurance you have, what time of day it is, that you should be offered, you know, anything but the best operation? And any layperson would tell you that makes no sense. It should be standardized, right? Everybody should be offered the best operation regardless of any of those factors. But we all know in the business that that's not how it is.
Yep.
And so this idea that everybody should have equality of access is really important. And so what we've seen, and we're doing some studies with Intuitive to look at these MIS deserts, and it's really interesting because you see that if you overlay you know, where the robotics, you know, where robotics and Da Vinci surgery has really penetrated, and they have the most access to intuitive, you know, instrumentation. In those areas, the adoption of minimally invasive surgery is much greater, because, and that just makes sense to those of us that do, you know, Da Vinci surgery, right? It's that, you know, we're more confident in being able to tackle harder things. So whereas there's a case where previously we would have just gone open with that because we'd be like, oh my gosh, there's no way. We're willing to try, you know, and that's the difference. And so for me, you know, when I'm thinking about whether or not, you know, I'm going to do something robotically, I always think, like, is it feasible? Is it something that I would offer my family and friends? And if it is, then I should, you know. The last procedure that I transitioned to Da Vinci surgery was an appendectomy. And I know people on this are going to laugh and say, you know, what are you doing? But the thing that really made me switch over was, number one, the pandemic, because everybody was sitting at home for 5 extra days with, you know, semi-perforated, awful appendicitis, and I was in there laparoscopic and chipping away with this crappy, you know, suction irrigator to try and, you know, bluntly dissect, and I wasn't happy with the stapling technology. And I finally said, you know what, why am I torturing myself?
Yeah.
You know what I mean? It was kind of a selfish decision on my part too, right? Like, I think it's better for the patients. I thought to myself, like, if I had my appendix that needed to be taken out, how would I want it done? And I'd want it done robotically.
But I think there's the question you just said, because I was going to bring this up when you talk about what would you want for your family, but I think sometimes you got to say, if it was me, how would I want it done?
Yeah.
Because I know what the risks are. I know what the advantages are.
Yeah.
And I know, like, when I went and had my hernias fixed, I had it done by my buddy doing it robotic.
Yeah.
And this was earlier in the course, but knowing what the difference was, I was like, I'm in. And some of the stuff I think that we found with the robot, it's difficult because you're not going to pick it up necessarily in the early data, because it's, we had this conversation, I said, there might be 15 or 20 gallbladders that I didn't have to convert because the advantages of the robotics vision or the articulation. And for those patients, it might not be enough to power the study and say, like, that's the difference. But if you're one of them,
oh, absolutely,
it's better than having an open procedure done.
Yeah.
So I think that's where sometimes it gets lost in translation.
Well, and you know, as surgeons, we think about it as, like, you know, oh, if I can't complete it, sometimes it's a failure, but it's not. And I said this yesterday in one of our talks. I said, if you started out robotically, if you start out Da Vinci and you can't finish it, it's not a failure, because you may have saved that person 6 inches of an incision. because you did a lot of the mobilization that you know what I mean, robotically. And so that is not a failure, you know what I mean? And so if I can, like bowel obstructions, for example, that's classically something that general surgeons said, you should just open. There's no way that you can see, minimally invasive. And then laparoscopic lice adhesions in certain cases, I think some people are like, oh, okay, I can do it. All of those cases, unless they're unstable, I put a camera in, because again, if it were me, I'd say, even if you have to open, you got to open. But if you can save half of the people a large incision, that in and of itself is saving a good number of people from having potential complications in the future.
Well, I think it's even more than that. I think that part of it, the more you do it, the next time, because part of it's the recognition. I mean, I always say surgery is rapid interpretation of visual cues. So the faster you can see patterns, the faster you can recognize them in terms of the learning process, because there's some things that you just have to see enough to go, oh, I know I can cut that, I couldn't cut that.
Yeah.
But the first time you see it, you're not sure.
Right.
You eventually take the risk,
Yeah.
and maybe that's the case where you took that risk, and the next time you're in there, you're
Yes.
like, I know I can at least do this.
Yes.
And now it's just getting the next step. But if you don't take that first step, you're not going to get to the 5th or 10th step.
Well, and bringing that back to colorectal surgery for me, when I look at my old videos, from when I first started, let's say in first colon resections in say 2018, when I started doing intracorporeal anastomosis, I look at them and there's videos where I diverted that patient, because I wasn't as sure, right? I was a little bit newer, and now I look at those and I'm like, oh, I would not divert that person now.
Yeah.
And let's be honest, diversion is kind of a selfish thing too, right? Because if I diverted everyone, nobody would ever have any kind of clinically significant leak, right? But that's not necessarily how you want to treat patients.
I would sleep so much better.
But you would sleep better, You're like, oh, they're diverted. Okay, I can sleep.
I think it's one of the hardest clinical questions.
Well, because you gotta pull yourself out of the equation, right? Because there is secondary gain behind diverting somebody, because you don't have to worry about it. Sometimes I roll the dice and I go, if it were me, I'd want someone to take the chance, and then I worry about it for like 5 to 7 days, and I'm constantly checking their heart rate's 110, and I'm like, oh God, here we go. You know what I mean? But we have to think about it in terms of for that patient, right? Like, it's not a non-morbid procedure to give someone a diverting ileostomy. It is a morbid procedure.
Even beyond that, as 6 years later, when you're fixing that hernia now from that ostomy that they may or may not have needed. And of course, all the social implications. I mean, I had a conversation with a couple, last night, I think Sages, and the PTSD associated with it. Some of these patients develop an absolute PTSD for dealing with the effects of our surgeries.
And their family members do too.
Yeah.
Because how many times have you taken somebody and you're like, well, we might have to do it, and they're like, oh my God, my mother had this, I had to take care of it. Like you know what I mean? Like they are just, they have like true PTSD from caring for someone with a stoma as well, because a lot of times people can't do it on their own. They're relying on their, husbands, wives, moms, dads, brothers, whatever. So it's like, it affects everybody.
So big takeaway from this, from a robotic standpoint, obviously I think the United States, we've really adopted the robot. I mean, and Europeans are starting to, I think, pick it up. I know there's some robots coming out of the Chinese area, they're moving, moving west, but you would say that we continue, even though it's not like the next iPhone iteration. This actually has a lot of improvements for the previous generation, and you're seeing actual true efficiency advantages.
Yes.
And outcome. What about outcomes? Are you seeing any improvement in
outcomes?
So
that's the thing, right? Again, when we talk about what is force feedback done, what we can see that there's less force on tissue. And if you ask a surgeon, if you can complete a task with 50% less force, will you do it? Would you prefer to do it with it? Everyone would say, well, of course, if I can complete the task with less force, great, What does that have in terms of clinical implications? That's what's coming up next. There are a lot of people that are doing studies on this in terms of decreased ileus and, and all of these things. So I think we need to be a little bit patient, and that's getting back to the point where I said about everybody wants to know how is it going to revolutionize my practice now. Yes, it is great. There are distinct advantages, but just wait and see. You know what I mean? The stuff that's coming down the pipeline in terms of the data and the outcomes and the updates it's gonna blow your mind. So.
Yeah. So this is just the beginning.
It's just the beginning. Yeah.
I was thinking about the plastic surgeons when I was in training. It was always soft, touch softly, careful the tissue, careful the tissue. And as a trauma surgeon, I was not always the most careful with the tissue. So this is going to force me to finally get there. Yes. Yeah. So, well, I just want to say thank you so much for your time. And once again, I hope you enjoy the rest of your time here at ASCRS, and thanks for coming to the Cutting Edge.
Thanks for having me.
Pleasure.